Hi, I'm Carol Gilling-Smith and I'm the Medical Director at the Agora Clinic, and I'm joined today by George Kustas, who is the Director of Embryology at the Agora Clinic. One of the most burning questions that I find people ask me when they want to use donor sperm in treatment, whether they're single or in a same-sex relationship, is should I do donor insemination or DI, or should I do IVF? And I think we're going to try and answer that today. There's going to be a few slides. I'm going to do a little bit of explaining, as so is George, and we're going to try to come to a few conclusions at the end. So sit back and relax, and hopefully we will answer that question one way or another for you. So I'm going to share my screen so that you can see the slides I've got ready. So DI, donor insemination versus IVF. That is the question. So starting off with this little scientific diagram, I'm just going to explain the big difference at the cellular level. In donor insemination, we put the sperm at the top of the uterus, and it will swim up the fallopian tube to reach the egg. Now, the ovary makes normally one egg each month. Sometimes in DI we use some fertility drugs to make 2 eggs or 3 eggs, but most of the time it's just 1 egg. And as the egg leaves the ovary and travels down the tube, it meets the sperm. And hopefully the fertilized egg will divide into 2 cells. The next day it'll be 4 cells. The next day it'll be 8 cells. It'll take 5 days, and it'll eventually reach the uterus where it will implant. And it's called a blastocyst. Now, we have no idea whether the sperm has actually reached the egg or got into the egg in this process. And also, we need to make sure the fallopian tube is healthy. So for most women who come and want to do donor insemination, they do have healthy fallopian tubes. But this is not an option for people with blocked tubes. In IVF, we've got a little bit more insight about what goes on, because instead of this happening in the tube, we collect eggs, and this whole process of fertilization and creating an embryo, which takes 3 to 5 days, it takes place in a Petri dish. So what are the steps involved in donor insemination? First of all, before any process, we need to see you, we need to assess your fertility. If you're in, it doesn't matter if you're a couple, or if you're single, or if you're trans, it doesn't really matter. We will do a fertility MOT. We'll see a consultant with the results of your test, and we'll make an assessment, and we'll discuss with you your plan, and then you'll go onto your program. So fairly unlikely that you'll need ovarian stimulation. Sometimes you do, sometimes you don't. Your cycle's irregular, but you will need ultrasound monitoring. If you need ovarian stimulation, it's very lightweight. It's usually tablets, very rarely injections. And we will scan the ovary over the course of 12 days, 14 days, so that we know when the egg is about to be released. For most of our donor insemination programs, we use a little trigger injection, which mimics your ovulation hormone. So that's really the only medication you take. And then we'll bring you in around 40 hours later to do the insemination. The sperm is prepared, washed in the laboratory, and inseminated into the uterus. And then you've got the 2-week wait. So probably anything from 2 to 6 weeks before you're ready to start treatment, depending on your period, about 14 days before your insemination, and then the 2-week wait before you know the result. When we do IVF treatment, a little bit more complicated, as you can see from this diagram. Same path to start with, fertility assessment. We need to know what your egg reserve is, you need a blood test and scan, and you need to see a doctor to plan the treatment. But we need to make more than 1 egg. So ovarian stimulation is inevitable. We use injections on a daily basis, usually over about 12 days, and we bring you in 3 or 4 times to see how the ovary is responding. Then you need obviously to have the trigger injection, as you do with IUI, and you come in to have an egg retrieval. So this is an outpatient procedure, but it is more invasive. When you're asleep, we give sedation, you have the eggs collected from the ovary. Then we mix the eggs and sperm in the laboratory dish, and we create from the egg and the sperm a fertilized egg, and we grow these eggs till they reach the blastocyst or day 5 stage, And then we do the embryo transfer. We prepare your womb lining and place the embryo in the womb and potentially freeze spare good embryos. And then it's the 2-week wait. So time-wise, it's all about the same sort of time, 2 to 6 weeks, depending on your period and what you want to do, about 19 days till we get to the transfer stage and 10 days until you know the result. All is the same. But IVF does offer a few more options. So it's the ideal option if you're in a same-sex relationship and you want to do reciprocal IVF. In other words, you want to donate your eggs to your partner. So one mum is called the biological mum. Her eggs are going to form the embryo. And other mum is going to be the birth mum who's going to carry the pregnancy. Both of you take hormones here, so it's double hormones. So biological mum will need to have ovarian stimulation and the egg collection. The lab work will be the same. Donor sperm is mixed with the eggs in the laboratory. And birth mum will have to take some tablets, usually HRT tablets, to build up the womb lining before we can do an embryo transfer. So she is going to carry the pregnancy. Timescales exactly the same, but look at that versatility. You can do this only with IVF. And the final little advantage of IVF, just in terms of, options, you can do something called egg sharing. So if somebody can't produce eggs, they've gone through an early menopause, they need an egg donor. And if you are fertile, you're 35 or younger, and you have a good egg reserve, you can donate half of your eggs as part of the IVF process. And that means your treatment is quite significantly subsidized. Now, what is the practicality of doing donor insemination and IVF? You need monitoring for both. And this diagram just shows you what we're monitoring. We're monitoring the way the egg is growing in the ovary, and the egg grows in a little sac of fluid called a follicle. So when you see those little black circles when you're having a scan, that is us watching how your eggs are developing until they are at the right maturity to be collected. Obviously, in donor insemination, if we don't do this, we may miss the time of ovulation. And we want to know that because that is what makes the success rate as high as possible. In IVF, we do it also to know when to collect the eggs, but also to make sure you're not under or over responding. So in IVF, you don't just have scans, you have blood tests to measure your hormones, estrogen, and to make sure you're responding well. And we are, in both cases, also measuring your womb lining, making sure that it thickens up nicely in preparation to receive the embryo. So that's how I sort of can represent an IUI or donor insemination, 2, maybe 3 scans starting around day 8 of your cycle, leading up to when the follicle reaches the magic number of 18 millimeters or more, and then the egg is going to be triggered to be ovulated. And in IVF, a little bit more going on. You'll feel it in the ovaries. Will you get side effects from the medication? Most women won't. A few will. You're obviously going to be producing far more female hormone estrogen, and there's more going on in your ovary. Medication is required. We know that if we do natural cycle IVF, which is when you just have the one egg, we're going to get quite a low success rate, which is why you need to have a combination of 2 injections. One is to stimulate the ovary, the other is to block ovulation. We'll be taking the ovarian stimulation injections for about 12 days. As in all of our treatments, you do need to have the medical and nursing consultations just so you know what you're doing. You are doing, in the majority of cases, it's very, very rare that people can't learn to do their own injections. You're doing these injections at home yourself. We're here just to monitor and support you. So probably about 4 scans rather than 2 or 3 in IVF, and then the trigger injection before the egg collection. Physically, what's it going to involve? What's it going to be like for me? Well, IUI does involve an internal examination at the point we put the sperm in the uterus. So although we've dealt with many, many patients who've had difficulty with internal examinations, it is that process of having a speculum examination so that we can see the cervix, and then we pass a very, very fine tubing into the top of the uterus to release the prepared donor sperm. It takes about 5 minutes. It's not usually painful, particularly in a fertility centre. You will always have experienced staff doing this. But for somebody that doesn't like internal examinations, there's no way around it. It's the way you do it in a clinical setting. IVF obviously involves a little bit more. Before I go on, I'll just say this doesn't require any form of anaesthetic. It's regarded as something you can do without any pain relief, although there are a few people that will find this so difficult they ask to have sedation. So it can be done with sedation to put you to sleep so that you don't have any awareness of the process. IVF is just that step more invasive because we've got two steps here. We've got to first collect the eggs and then replace the embryo into the uterus. The egg collection part is always done with sedation. You're asleep, but when you're asleep, you're scanned internally. And as you can see here, a very fine needle will go into the ovaries to collect the eggs. And it takes about 20 minutes. It's normally a sort of 20-minute procedure. You're with us for an hour or two afterwards, and then you go home and you have the day off work because you've had some sedation. But it is a minor procedure, but it's probably the part that most patients, I think, fear most, but it's actually not that difficult. When you've been through it, you'd say, actually, it wasn't that bad. I'm going to hand you over now to George, because what happens then in IVF is really interesting. You get a lot more insight into what's going on.
So when we collect the eggs, we handle the eggs in the laboratory by the embryologist. Previously, you saw a photo of how the lab looks inside. Now with IVF, and the beauty of IVF is that we see everything under the microscope, and usually we record everything. Now, what we see when we fertilize the eggs and wash and prepare the sperm, we see that under the microscope, and we monitor every step of the growth of the embryos. Here you can see an egg that sperm has been washed and prepared, similar to IUI, but now everything happens in the lab. We can see everything. And following insemination, we leave the eggs in the lab overnight in a special incubator, and the day after we assess for fertilization. Now, these are the incubators.
I'll go back, that's the incubators there.
Yeah, these are the incubators where the embryos grow. It has special conditions to allow the embryos to grow. They look like mini toasters, and every patient has their own incubator. And below you see a time-lapsed incubator where it takes a photo of the embryo every few seconds, and it creates a video. So you have a video of your embryo development at the end of your treatment. Now, what is fertilization? Fertilization, it's an egg that has been normally fertilized by a sperm. So a single sperm has entered the egg. And here we can see a beautiful normally fertilized egg that has two circles. One circle is DNA from the sperm, and the other one is DNA from the egg. We grow the embryos in the lab day by day for 5 days. On day 2, we want to see embryos that they have between 2 to 4 cells. On day 3, 5 to 8 cells. On day 4, the embryos, they keep growing. At this stage, they have over 40 cells. And then on day 5 is the day that we assess the embryos, and we select the best one for your embryo transfer. The embryo on day 5, it's called a blastocyst, and you can see here it has a mass of cells that will make the baby, and cells that they surround the embryo that will make the placenta. You will also, at the day of your embryo transfer, following assessment of your embryos, we will also inform you if we have any remaining embryos for freezing. Now, in theory, when we start with 4 or 5 fertilized eggs, at least one should reach the blastocyst stage. Our data show that same-sex couples following IVF with donor sperm have over 90% chances to have a second embryo frozen that will be used for a future frozen cycle. And that's one of the advantages of doing IVF. You will have an embryo in storage of good quality for another pregnancy, and you could also donate that embryo to your partner.
So That's really great, George. I mean, that sort of 5 days in culture is an amazing experience. The embryo comes out, it's selected, and we normally we would be having a conversation with you to explain exactly where the embryo's got to. It's a laboratory conversation as well as a medical conversation, so that we pick the very best embryo, put one back into the uterus. And this process of embryo transfer is just very similar to the IUI, except we tend to do this with an ultrasound picture of the uterus. We put a tummy scan on, so we know exactly where to place that embryo. So it's again an outpatient procedure. Both partners can be there in a couple, and you have a picture of your embryo to take away. And as George said, potentially from that one cycle, you've created further embryos to freeze if this cycle doesn't work, or if you do get pregnant and you want a baby further down the line. Now, these are data from the Agora on same-sex couples, single women using donor sperm. So these are IVF success rates, clinical pregnancy rates per embryo transferred in the different age groups. So overall, if you're under 38, an overall chance of a successful pregnancy of 45% from a single IVF cycle. Whilst showing this, I'm also going to say that one IVF cycle can generate embryos to freeze. And George, correct me if I'm wrong, but our current frozen embryo cycle pregnancy rates are very similar to these. So a single frozen embryo thawed out and transferred into the womb will give very similar results. And what you'll see from this graph is it's not typical of the results when you do IVF in a heterosexual couple where there are fertility issues. So you do get, on general, better results across all age groups. So let's compare that graph with the similar results for a cycle of donor insemination in the different age groups. I think you just need to have a look at the different age groups. You're probably just going to go straight to your own age, but your age is at the bottom. Pregnancy rates. So these are clinical pregnancy rates. We've given you up-to-date data. They're not the live birth data, but this is the data we submit to the HFA, clinical pregnancy rates in same-sex couple or single women using donor sperm. So we're seeing here, obviously, the difference that you would expect from a single cycle of donor insemination and then a single cycle of IVF with one embryo going back. But just bear in mind that that one IVF cycle can create further cycles of frozen cycles. Cost, really, really important. Nothing more can be said about cost. It is more expensive in every way to do IVF than donor insemination. I'm giving you the Agora prices. It'll be the same sort of difference in most IVF clinics, because IVF involves lots of steps, involves lots of people, involves lots of lab work. So not surprisingly, you'll be paying on average £5,000 for an IVF cycle, whereas an IUI cycle would be perhaps just under £1,000. We do a 3-cycle package of donor insemination for, in fact, it's not correct there. It's about £2,000. It's incorrect there on that data, but that doesn't include donor sperm costs. Donor sperm is a separate cost, and different donor banks provide you with different costs. I always say budget for about £2,000 separately for the donor sperm for 3 cycles. So IVF is going to be significantly more, and you've got medication costs. One option which has been obviously very, very popular with same-sex couples or single women, if they're 35 or under, is to egg share, because as you can see, the cost of the IVF is significantly less, but it still gives them the same success rate as if they weren't giving away half their eggs. They may not always have many embryos to freeze because they're giving away some of their eggs, but they should get exactly the same success rate per cycle. And of course, you can see the combination of doing intra-partner egg donation is more than just IVF, because there's 2 cycles to manage. There's both the preparation of the womb lining for the birth mother, as well as the IVF cycle. But you can, in reciprocal IVFs, do egg sharing as well. So there is a real buzzword at the moment in IVF, which is personalized medicine or personalized care. And that really is, it's what I want, the take home message, you know, I'm going to give you all the pros and cons in a minute, but the take home message is there is not a one size fits all. You need to start with a fertility assessment, whether you both do a fertility assessment as a couple to see whose egg reserve is better, who should go first, whether you can donate, or whether it's just one of you who does the fertility assessment. A blood test and scan to look at your egg reserve, followed by a doctor's consultation, is the starting point to all discussions. And then with that information, you can go on and plan your treatments. So, IVF, pros. We've talked about higher success rate, at least 3 times the success rate per cycle. Time to pregnancy is usually reduced because in a single cycle of IVF, you know, your higher success rate will mean that you get pregnant probably quicker overall if you looked at a large population of women using donor insemination or IVF with donor sperm. It is a better option if you've got a lower egg reserve for 2 reasons. You can freeze embryos. So if your first cycle doesn't work, you don't have to go through that cycle again, but also you can preserve your fertility. You may not want to be pregnant immediately, but if you do an IVF cycle, you can create embryos with donor sperm and maybe 2 years, 3 years down the line, come back and use those embryos. You can donate your eggs to your partner, or indeed the embryos created with donor sperm to your partner. As George pointed out, you can get a lot more information about your eggs and your embryos. You can't see it in donor insemination. So when a donor insemination cycle fails, you can just scratch your head and say, well, the sperm was fine, everything seemed to go fine, why didn't it work? We don't know really, but with IVF, you can go and scrutinize a little bit more what went on. It's not unusual for people to move on to IVF treatment after failed donor insemination. 3 cycles failed, they come to me and we do IVF. Against IVF is definitely, it's more invasive. You have to take the ovulation, ovarian stimulation medication, the injections. It's more expensive, although we have the option to share. Potentially more side effects, although not commonly reported. Medication can in some patients cause side effects, hormonal side effects, and there are small risks. Over responding to the drugs, for example, and slightly more visits to the clinic. If we look at donor insemination, it's less invasive, fewer clinic visits, it's simple. It's often the case that it's actually, the cost is so much lower that it's the first option. And it's definitely, you know, very popular, particularly in younger, I think, women. But just remember the cons, and you know, remember that the success rates and the time to pregnancy may be longer. You can't freeze your embryos for the future. You can't donate to your partner. So if I'm going to conclude, I think, you know, we've definitely felt, George and I, over the last 2 or 3 years, that IVF should come up in the conversation far sooner when we see patients who want to use donor sperm, because it's often overlooked. It's regarded as too invasive, too complicated, too expensive. And I think that diagram which I showed you about personalized medicine is pretty well the take-home message diagram for me. Is we want you to come in, we want to see what your egg reserve is like, we want to see what your age is, we want to know what you personally feel about the 2 processes. So, and then we can make a really good decision based on your own personal wish and what you want to do. So I'm really hoping that we've covered everything there, George. Is there anything that I've missed out that you think we should say?
No, I think it was a good overview, and the message is clear out there.
Great. So I hope you found this all very helpful.